Thank you very much for your kind invitation to come to this very famous institute. The first time that I'm here, although I know Professor Sarin for a long time. Yesterday we recall it was like 30 years, more than 30 years, right? Today I will give you a little overview about the role of the gut, nutrition, and certain factors, with a focus on wheat, which is a very important nutrient, on inflammation, and also on extraintestinal diseases, including liver diseases, just highlighting a few principles of signaling from the gut to the periphery, as we say. So I don't have financial conflicts of interest. I'm just PI on a few studies, especially if as regards this topic on celiac disease and pharmacological therapies, where I'm a PI in 4 studies. So the gut definitely is important in modulating human health. So it harbors the largest immune system of the body in the gut lamina propria that underlies the epithelium. The gut has to learn to interact with a lot of nutritional substances as well as microbial signals. So it has to develop a very intricate immune system to differ the good from the bad that comes from the gut lumen. And that reflects also on other tissues of the blood via the bloodstream, where immune cells from the gut can go along to peripheral organs as well as metabolites from bacteria in the gut lumen. So signals from the gut affect human health, and this is a really emergent topic in medicine, that gut health, healthy nutrition, healthy microbiome, and metabolites is crucial to human health. And here you have just an example on the organs that are affected by gut signals. So what happens in this little bit busy slide is you have the intestinal lumen. I'm looking for a pointer here. In the intestinal lumen you have nutrient fragments mainly. You have gut metabolites, and you have the intestinal barrier. Normally the intestinal barrier is semi-permeable, so minor amounts of nutrient molecules that also have immunological functions come into the lamina propria below the epithelium, as well as certain microbial metabolites, and these affect the immune system. Normally the immune system from birth on is primed for tolerance when the infant has been exposed early on to a broad spectrum of hitherto unknown substances. Not in a large amount, but in a smaller amount to learn active immune tolerance, as depicted on the left side. Signals are interleukin-10 by myeloid cells, TGF-beta, IgA production, etc. And if this gut barrier is broken due to external influences, can be medications, can be infections, or can be the lack of early exposure to a lot of diverse nutrients, then allergies and autoimmunity can develop. I will talk about a very important nutrient, also in India now, especially in the north, which is wheat. And wheat is okay for most people, but there is a very significant amount of people in the population that have an adverse reaction to wheat. The first is celiac disease, which is very well defined. It's a reaction, T-cell reaction to gluten proteins based on a genetic predisposition. Then we have the typical classical immediate type wheat allergy, that all of you know. It's Baker's asthma. It's an inhalative allergy, but also nutritional allergy. It's pretty rare. Then we have a novel type of food allergy, which is mainly directed to wheat, which is prevalent in irritable bowel syndrome as a major cause of this condition, which is very frequent, up to 10% in most populations. And there, wheat proteins are a major delayed type allergen, a type 2 allergen. And there is what we call ATI sensitivity. ATIs are amylase trypsin inhibitors. They are non-gluten proteins of wheat, representing about 3% of the wheat proteins compared to gluten, which is about 80%. And these ATIs can activate the toll-like receptor 4 in the gut myeloid cells, and this has effects on intestinal and extraintestinal inflammatory diseases. I will give you examples of all. Irritable bowel syndrome is related very much, 70% of the people, to these type 2 food allergies as a major trigger. And what we call non-celiac wheat sensitivity, inflammatory wheat sensitivity, encompasses these type 2 allergies as well as what we call ATI sensitivity. So wheat is a pretty recent grain, so it's new to mankind. It has been grown first time about 11,000 years ago and has reached Europe as well as India a little earlier, of course, India. Europe around 7,000 years ago. I don't know exactly about India. It originated in the Middle East. So wheat production is huge in the world. It comes directly after corn and has become a major staple also in former rice, etc., consuming societies. So wheat proteins are about 10% of the dry weight. 85% is gluten proteins, which have a specific structure as depicted here. There's glutenine, which are cross-linked chains, and in these cross-linked chains there's gliadin molecules embedded, more globular, and this gives wheat products the crunchy, tasty flavor of gluten-containing foods. So therefore, in the food industry, gluten-containing foods are extremely important. And about 15% of the proteins are non-gluten proteins, and about 0.3%, 3 grams per kilogram dry weight, is the ATI proteins that activate toll-like receptor 4 in the gut. The wheat proteome is the most complex proteome among all plants. It contains 103,000 expressed genes, highly homologous in part, and that is about 4 times to 5 times as many as we as humans have, although we as humans have a more complex gene regulation. So what is celiac disease? The first entity, it's an intestinal inflammation caused by gluten proteins. The prevalence is around 1% also in most parts of India. And it's a Th1 T cell reaction, an aggressive T cell reaction that leads to characteristic mucosal changes like this complete villus atrophy compared to a normal villus structure in the upper slide. And at first diagnosis, when people still have active disease, you normally have this total or subtotal villus atrophy in duodenal biopsies. And the clinical picture ranges from a few symptoms nowadays to severe diarrhea, the classical symptoms with malabsorption. Patients often have atypical symptoms. It's the so-called chameleon of internal medicine. And many of these atypical symptoms are autoimmune-like or autoimmunity. I will shortly refer to that. And if celiac disease goes on undetected for a long time, otherwise rare complications can occur, like refractory celiac disease type 2, which is a semi-malignant disease on the way to EATL, which is an intestinal T-cell lymphoma. Also, patients can develop intestinal adenocarcinoma, an otherwise very rare condition. The risk is about 200-fold in active celiac disease that lasts for decades undetected. And the clear diagnosis nowadays can be done by a serological test that many of you know. It's autoantibodies to tissue transglutaminase, or TG2, one of the best tests in internal medicine nowadays in terms of sensitivity and specificity. And the therapy, a strict gluten-free diet, appears easy, but is not easy to maintain. Important to know is that about 30% of the population of the celiac people have one or more autoimmune diseases. So it's really a search function for autoimmunity. There's the celiac iceberg. Some people develop the classical symptoms. Other people rather have signs of malabsorption, including anemia, but also otherwise unexplained hypertransaminasemia. A few patients even liver failure. There are some reports in the literature with severe celiac disease that has gone undetected for a long term, and autoimmunity, mainly autoimmune thyroid disease and type 1 diabetes. Long-term celiac disease increases the risk for lymphoma. And there's psychiatric conditions with a threefold higher prevalence of schizophrenia among active celiacs, ataxia, autism, migraine. And there are certain genetic syndromes like trisomy 21 with a very high prevalence of celiac disease, up to 10%. So this is the cofactors of celiac disease. On the right side, you see that if people have stress, they are more prone to get a bout of, for example, inflammatory bowel disease. The same is true for celiac disease and other autoimmune diseases. There's microbial factors that can promote celiac disease, the bad bacteria versus the good bacteria and their metabolites. There's additional dietary factors, like if the child is exposed to high doses of gluten very early on, like 150 years ago in Ireland, they were fed with gluten very early on, and the prevalence was very high in classical celiac disease in Ireland. And there is additional genetics, apart from what is shown on the left side. The so-called necessary but not sufficient precondition for celiac disease is the presence of the antigen-presenting molecules HLA, DQ2, and DQ8, which are prevalent in about 30 to 40% of our populations, and which are necessary that celiac disease can develop. You will see the reason why this is necessary. 70% of the population don't have these genes. They never develop celiac disease. But also, if you have this predisposition, your risk is only increased threefold to develop celiac disease. And how that works, I will explain later. This is just to show there have been a lot of correlative fecal microbial studies in celiac disease that correlated certain populations of microbiota with the disease. I'm not sure if that is a very, very strong determinant in children and adults. So I will just go over it. What are the practice recommendations before I get to some more mechanisms and pharmacological therapies and the need for them? Celiac disease is the cause or in association with a multitude of unclear symptoms, autoimmune diseases, and what is important to know, first-degree relatives of a celiac patients have a 15% risk to also have celiac disease, and a highly increased risk with or without celiac disease to have autoimmunity, like type 1 diabetes, autoimmune thyroiditis, rheumatoid diseases. If you have a suspicion, there's a recommendation to do serological testing for transglutaminase autoantibodies. In the majority of the people of the IgA class, there are a few IgA deficient patients. This is not a lethal condition, but then you also test from the very first instant on, usually for IgG antibodies, because they are then IgG antibody positive. One of the best tests with sensitivities and specificities close to 100% with active disease. There's a lot of unclear and complicated cases, and for that you need a celiac center, like Dr. Maharia in Delhi. He's an expert, international expert on celiac disease. There is the refractory or semi-malignant or malignant types of the disease, and especially the enteropathy-associated T-cell lymphoma is almost impossible to treat. It's still a pretty lethal disease. Only bone marrow transplantation can help some people. So you need expert centers. And what is very important, it's very easy to avoid foods like this, where you know there's gluten in it, but essentially all refined, non-declared, non-gluten-free declared foods can contain traces of gluten, especially all processed and refined foods. So if people have celiac disease, they have to completely exclude any trace of gluten that can trigger the immune response. And they have a hard life, hard social life, and if they are business people, it's very difficult to eat out, for example, to be sure there's no gluten and traces in the food. So that means maintaining a gluten-free diet is very difficult for many patients, and in some patients the perceived quality of life can be close to that of hemodialysis patients, because they must be afraid of having gluten contamination in everyday life. And a minimal gluten ingestion is, even if it's a few milligrams, is almost unavoidable. And about 40%, up to 40% of the people with celiac disease who are on a strict gluten-free diet still have complaints. Not as much as with a full gluten diet, but modest complaints, and also histological damage, mild villus atrophy. And that means for the patients and in general that a supportive medication for a majority or a significant amount of patients is needed, a supportive pill to protect from these minor gluten contaminations and to induce complete healing. So patients usually are associated with a good dietary advice and a celiac society. And this is just an idea how much gluten you have in certain foods. Macaronis, this is about 200 milligrams. This is about, one macaroni is fourfold the amount that is allowed, or even nowadays tenfold the amount that is allowed for a celiac patient. It's tenfold above the daily threshold, a single macaroni, for example. And an inflammatory reaction can occur with as little as 10 to 50 milligrams. That's a study from Italy over 12 weeks, causing intestinal damage and also complaints. And this is compared to about 15 grams of gluten that you ingest with a normal gluten-containing diet per day. So had we known this, we would have rewritten the old European fairy tales like Hansel and Gretel, where the gingerbread house was a very important component. So what about the pathogenesis and pharmacological therapies which are coupled to the pathogenesis? So here you have the intestinal epithelial lining, and the epithelial cells sit on a basement membrane. Below the basement membrane you have the lamina propria, the largest body's immune system, in this thin layer surrounding the intestinal lumen. A certain amount of any kind of foodstuff, fragmented or not, gets into the lamina propria, which is important for tolerance sensing, as I've mentioned before. And gluten peptides are not that easily digested. There's remaining fragments after digestion, 10 to 30 amino acids long, and part of these fragments are immunogenic for celiac patients, not for the general population. And especially when they come into contact with the autoantigen, for which we have the antibody assay, this autoantigen is involved in the pathogenesis of celiac disease because it can specifically react as an enzyme with the gluten peptides and change the gluten peptides with a charge change, which I will explain in a minute, and also cross-linking to the gluten peptides. And this change of the gluten peptides, so the squares are the enzyme and the circles are the gluten peptides, and the color change means the gluten peptides are changed in their surface charge, and this change in the surface charge improves their binding to the predisposing HLA-DQ2 or DQ8 on antigen-presenting cells, which are macrophages, dendritic cells, but also B cells. And this antigen presentation then triggers an activation of these myeloid cells themselves, which has a role in so-called intraepithelial lymphocytosis. But more importantly, it can trigger gluten-specific T cells. So the body has a whole range of different T cells in a very low amount that can react to any kind of presented antigen And when celiac disease is initiated, of course, there's very few gluten-specific T cells that can then expand dramatically, proliferate, be activated, and expand. And then you have a large pool of gluten-specific T cells after a few weeks when celiac disease develops. And these T cells are tissue destructive. They behave like sensing an external bug that invades the intestinal lumen, so a danger signal to which T cell responses are needed. And the activated T cells then via cytokines can activate myofibroblasts. These myofibroblasts can then remodel the intestinal mucosa and promote what you see with villus atrophy and crypt hyperplasia, the typical celiac histological lesion. And they can also stimulate B cells to produce antibodies against gliadin, not very specific for celiac disease, but antibodies to the autoantigen tissue transglutaminase are highly specific. And these can then be secreted into the blood in an overflow reaction, and that's what you measure with active celiac disease. And they are primarily of the IgA class because this is a mucosal reaction. So what about therapies? When we talk about adjunctive or supportive therapies for those celiacs who do not get into good remission, to date there is no approved such medication. There is certain synthetic or semi-synthetic glutenases which are pretty active in completely degrading the gluten so that it's not antigenically binding to DQ2 or DQ8 anymore. There is a role of biologicals like for inflammatory bowel disease, like anti-interleukin 15, which is important for also gluten-specific T cells, and OX40 ligand. There's a clinical study now that is important for antigen-presenting cells and T memory cells. There is small molecules that help to stabilize tight junctions that not so much of the gluten peptides get in. And there's tolerance-inducing nanoparticles. I will shortly mention that. And approaches that we also follow in our little biotech company, blocking the DQ2 or DQ8, which is not important for general defense because 70% of the population do not have these DQ2s. If you block them with a small molecule, you could prevent celiac disease. And there's transglutaminase inhibition, the enzyme that is involved in potentiating the immunogenic potential of gluten peptides by changing their charge. So I will refer to this very shortly and to that a little bit more in detail. So what about tolerance induction by nanoparticles? The company Takeda has a nanoparticle large size which goes to the spleen when injected intravenously. And you can load these nanoparticles with your autoantigen, or in this case with gluten. And when it goes to the spleen is primed for tolerogenic T cell production. And these tolerogenic T cells do not remain in the spleen, but they can home via specific T cell receptors to the organ where the, let's say, inflammation is going on. In this case, in the gut, and it will go towards where the T cell reaction, the aggressive T cell reaction to gluten occurs and can suppress it. And I will not go into detail because we don't have too much time. I will skip it. There had been preclinical data in animal models in type 1 diabetes and in a mouse model for celiac disease that we developed a long time ago in Boston. And I will just go over it. There has been a proof of concept study in 39 patients who were challenged with gluten, celiac patients in remission, voluntary challenge, and signs of efficacy could be shown in a short-term study, but not signs that would prevent villus atrophy or intraepithelial lymphocytes. Other nanoparticles go to the liver. I also don't have time to go there. It's not well published. We just did animal experiments on that. These liver nanoparticles loaded, again, in this case with gluten peptides, when they are loaded, for example, with neuropeptides like MOG peptide, they can suppress multiple sclerosis in mice. Okay, we'll just skip that, and now we go to transglutaminase 2 inhibition. What is the basis for this? We have triggers of celiac disease, which is dietetic gluten, which is present in 100%, of course, of the diseased patients. We have the genetic predisposition that is occurring in about 30% of the population. All these have to be there. We have autoimmunity to the body's own enzyme, tissue transglutaminase, and often triggers in children as well as adults of a breakout of celiac disease has something to do with the break of the barrier. So it can be infections, viral infections. There have been reports from Sweden. Viral epidemics increased the prevalence of celiac disease dramatically. And what does the enzyme tissue transglutaminase do? Here you have a one-letter code peptide that can bind to HLA-DQ2, which is shown above, with a 9 amino acid binding pockets which have preference for hydrophobic H, negatively charged amino acids. So this is a typical gliadin peptide with a sequence in which one position can be changed by the enzyme transglutaminase. A Q is a glutamine residue. The gluten peptides are very glutamine rich and proline rich. And this glutamine residue can be deamidated from a neutral residue to an acidic glutamic acid residue within the peptide. And if this peptide now binds to DQ2 in this case, you can see that there's a preference for negatively charged and hydrophobic amino acids. So in position 6, there's 9 binding pockets here. There's a preferred binding of a negatively charged molecule, and the activity of the transglutaminase enzyme has produced this negative charge from a Q to an E. So there is a better fit for DQ2, although the other fits are not always perfect, like proline, hydrophobic. Y is tyrosine, hydrophobic, that's fine. Leucine, L, rather negative required, it's hydrophobic. But this is the typical precondition for autoimmunity, that you have a fit but not a perfect fit. Here you have a non-perfect fit, which is slightly improved, obviously to be the ideal fit for T-cell activation. If the fit is too good, there will be auto-elimination of autoreactive immune cells. So there has to be some kind of improved intermediate fit which occurs with this enzymatic reaction. And then the T-cell receptor on the gluten-specific T cells can react and induce a proliferation and activation of gluten-specific T cells. So this small molecule is a tetrapeptide analog. So it's like a tetrapeptide, but it has modifications that makes it very stable. And this tetrapeptide can occupy, this is an X-ray structure, it's not alpha fold. Alpha fold is not exact enough yet. Normally the enzyme binds to a substrate, a glutamine-containing protein with a certain sequence environment, like these gluten peptides. There's a few others, but very few only, that can react with it. And the open conformation on the right side then reacts with a substrate and can do a transamidation reaction. Either it's a cross-linking or a deamidation reaction. So, and this tetrapeptide analog fits perfectly into this binding pocket and causes an irreversible inhibition of this enzyme. So this inhibitor is irreversible. It's highly specific for the enzyme TG2 that plays a role in celiac disease. There is 7 more transglutaminases, including factor 13, that is important for blood coagulation and wound healing. And this factor 13, of course, you don't want to inhibit, so it must be very specific for this enzyme. And it blocks gluten deamidation and therefore immunogenic activation of the gluten peptides in the gut mucosa, pretty specific for the disease. And it's orally available as a pill and mainly active in the gut, and there is no major extraintestinal side effects as evidenced in phase 1A and dose escalation phase 1B clinical studies in more than 100 patients. And therefore we embarked on a trial that was published in 2022 using this molecule in 160 patients. Let me just see phase 2A study, 160 patients, volunteers with celiac disease in remission. And they were challenged for 6 weeks with a gluten-containing cookie, which is about 20% of the usual daily consumption, that induces enough modest damage to see histological changes and maybe patient-related outcomes, worsening of some symptoms, not so dramatically. And the drug was given in 3 doses or as a placebo, groups of about 40 patients each. And the primary endpoints were histological, hard endpoints, villus height to crypt depth, pre versus post, or post versus pre. Secondary endpoints, intraepithelial lymphocytosis, resorption parameters, enzymes, and PROs, patient-related outcomes. And as you can see here, on the upper right side, you see on the right side the pre and post villus height to crypt depth. So you see there's a very significant drop, as you see in active celiac disease, without drug treatment, but a gluten challenge, a modest gluten challenge. And from left to right, you see a dose-dependent normalization of the villus height to crypt depth in these challenged patients. And when you look at the intraepithelial lymphocytes, same thing on the very right side, pre and post. In the patients, you see an increase in intraepithelial lymphocytes, a secondary histological endpoint, and with an increased dose of the drug from 10 to 100 milligram once daily, you see a normalization despite a gluten challenge. If you look at the PROs, you can see that the red people during the 4 weeks of the treatment, this is the 6 weeks, this is a 6-week time point, there's a clear drop in the PROs, celiac disease specific symptom score, which goes up in a follow-up of up to 10 weeks to normal again, and all the treatment groups dose-dependently improve their PROs to normal. And for us liver people, also slightly elevated liver enzymes, which you have as a kind of bystander hepatitis, gut-liver axis, barrier defect due to active celiac disease, as in IBD, for example. Also, the liver enzymes were completely normalized. So there's quite a few other therapies in clinical studies. The most promising is perhaps the anti-OX40 ligand antibodies. That's a study where I'm the PI of 70 centers. The other studies are more or less developed, but the most relevant is the transglutaminase inhibitor as an oral drug, potentially a standby drug that patients could take when they are in danger of having gluten contamination. It addresses a very central pathomechanism of celiac disease. It doesn't interfere like a biological with general, let's say, mechanisms of disease, potentially with side effects. So it improves also an extraintestinal manifestation, the liver enzyme elevation, and the PROs. And we have just finalized a so-called phase 2B study in 400 patients, 100 centers worldwide, with the drug in a real-life scenario, patients with ongoing symptoms, and these are quite a few, as I showed you, and 12 weeks of treatment, and again, histological endpoint, and this time combined with an improvement in patient-related outcomes. And at the same time, we have a similar smaller study in 70 centers where patients receive placebo-controlled a very minimal amount of gluten, an equivalent of 250 milligrams per day for 12 weeks. So, and in the last minutes, I will show you a very important thing. It's what we call type 2 allergy against mainly wheat, but not exclusively wheat. This is the classical allergens, mainly in children, food allergens, and they are pretty frequent in children. They fade away in most of the children after a while, but adults still have a prevalence of immediate type food allergies up to 4%. These are, of course, immediate type. They are IgE, mast cell related, and the patients have frequently a positive IgE or skin test, not a very good test, and it can really be dangerous as an anaphylactic reaction. This is very different from what we call type 2 allergy, which is much more frequent. So we selected IBS patients who were reactive with their symptoms to food. And as mentioned, IBS is very prevalent. Also in India, it's at least 10% of the population. Ongoing intestinal problems with fatigue, with a general ill-being, brain fog, etc. So we selected these patients. We put them on a 3 to 5 day diet, very basic diet with non-allergenic foods like rice or potato plus olive oil and salt and water. And 70% of the people in the average improve with such a basal diet with IBS. That means food is an important trigger of IBS. We selected out of these 70% patients and subjected them to endoscopic food challenges in the duodenum via the channel of the endoscope in a volume of 30 ml. Standardized solutions or suspensions of milk, soy, yeast, wheat, very frequent food, basic foods. So what we could see in a high proportion in our first study in 2014, that quite a few IBS patients react to one of these, very few to two of these, and that wheat is a predominant trigger, followed by milk, soy, and yeast. What you can see when you inject the patients with fluorescein, with a magnification endoscopy, which we call CLE, you can see under magnification live that there is an explosion of fluorescent fluid between or with the epithelial cells. There is epithelial cell shedding within 2 or 3 minutes of application of the implicated food. You can quantify this by fluorescein egress. And what is important, that among 36 patients in our first study, 22 reacted with one of these compounds, others against mixtures. But we just have a look here on these 22 out of 36 reacting to one of these, major big four, and 13 out of these reacted to wheat. And as I've mentioned, wheat has a very complex proteome. And when these 22 patients were put on the defined exclusion diet, they essentially improved over a year to normal in terms of their IBS symptoms. And what is important here, that symptomatology is delayed. Although you see an immediate reaction proximally, patients usually have complaints many hours after they ingest the food. It's not IgE mediated. And I will show you how this technology works. It's a series. You inject the patients with fluorescein, which is harmless. You do an endoscopy, 1,000-fold magnification. You put your probe tip on the epithelium in the duodenum where you applied the liquid or the allergen. Here you see no reaction with milk. Or the basic reaction is the endoscope. These are the solutions. Here you give milk, and you saw no reaction. That was a little bit mixed up. Here you apply wheat, and you see a difference like between night and day. So it's a really dramatic explosion of fluid into the lumen. It's the inverse leaky gut. So in a second study published in 2019, we showed that there's histological changes. There's an increase within 30 minutes pre-post in histology of intraepithelial lymphocytes. They increase further within 30 minutes after challenge significantly. There's an eosinophil reaction, not an IgE-mediated reaction. There's an increase of eosinophilic cationic protein and eosinophilic marker in the duodenal fluid. There is a decrease in the tight junctional protein occludin that you can see histologically after a positive challenge, and an increase in claudin 2, very similar to active inflammatory bowel disease. You also see these tight junctional protein changes. And the patients have a family history of atopy, 4-fold higher than in the average population. And again, in this larger study with 125 selected patients, again, the majority, 60%, reacted to wheat proteins, and followed by milk, soy, yeast, or egg in mixtures with nuts. So this is the paradigm underlying it, intestinal barrier defects that can be triggered by infection, by certain medication like non-steroidal anti-inflammatory drugs. Even stress can decrease the intestinal barrier integrity. And then you can get a vicious cycle of autoinflammation in an allergic way, but also autoinflammation that can promote general inflammatory conditions. There is more inflow then of detrimental bacterial components and also allergenic or detrimental food components. And this is very important because this is an area that it's expanding dramatically, intestinal barrier defect, what people call leaky gut, not that correctly. Just highlights, this is, I won't go into any details because we have to slowly come to the end. We have done proteomic studies of modern versus ancient versus intermediate wheat varieties. 150 wheat varieties measuring more than 3,000 proteins by quantitative wheat proteomics. And we could show that the proportion of proteins that are potentially or proven allergenic proteins in wheat is very high in modern wheat with many, essentially 100,000 expressed genes. About 8% of these genes are potentially allergenic. So it's a dramatic potential allergenic load in modern hexaploid wheat. When you compare to ancient wheat like einkorn, which is a very simple wheat, which you can also buy and is grown, I think, in part in India too, the allergenic potential is much lower. The proportion of allergenic proteins is 1.8%, so it's about 1/5 of modern hexaploid wheat. So this just exemplifies that modern wheat has more allergenic potential, much more than ancient wheat varieties. So I will skip that. The type of inflammation, type 2 on the right side, this is the very frequent delayed type. It's eosinophilic, a little more ILC2. On the left side, you have the classical immediate type reaction. So if you summarize that, I think we can skip this now. Practice recommendation is, it's a major trigger of irritable bowel syndrome. The recommendation is you can put the patient on a basal diet for 3 to 5 weeks. If the patient improves, it's clearly related to this type 2 allergy, or much of the IBS is related to it. So in case of improvement, you can just, in a targeted way, eliminate wheat and perhaps also cow's milk. And then you already have hit quite a few patients, and they will respond pretty well. And then you can also exclude maybe the other ones like soy and yeast. And if there's no clarity yet, you can do a confocal laser endomicroscopy, which is a prolonged endoscopic procedure, 45 minutes. And if you test positive once, you have to stop because it's so positive you can't test another one. And some patients also have baseline leakage. Very interesting in terms of autoimmunity. They have the baseline leaky gut. So it is possible that later on with this kind of allergies, you can start again to induce tolerance. Of course, you have to exclude the detrimental food stuff, but then maybe slowly some tolerance can develop again. So that's a general paradigm here. So, and restitution of an intact mucosal barrier in this, but also autoimmunity is very important. So if you give me 5 minutes more, do you have 5 minutes more for me? I will talk about another practically very important topic, which is ATI sensitivity. ATIs are wheat amylase trypsin inhibitors. You have similar molecules in other staples, but they don't have TLR4 activating activity. They are largely undigested by intestinal enzymes, so they remain intact essentially down to the colon. And there is 7 prominent species in most wheat varieties. They have a role in grain maturation and also pest resistance. And the TLR4 stimulatory bioactivity is highly variable, even in modern wheats. There are some variants with low activity and some variants with very high activity. There is no such activity essentially in gluten-free staples. So it correlates with the gluten content, and baking or cooking doesn't lead to significant losses of activity. And since our first description, that was an NIH project in Boston, in JXMed of this. It's a very thorough paper if you're interested on the mechanisms and how we found these ATI molecules as stimulators of innate immunity in gluten-containing foods. We and some others published quite a few papers on the ATIs, including many experimental animal models, but also, and I will show you that very shortly, some human studies. So studies in mouse models can be done with purified ATI proteins in a otherwise completely identical diet. So you put animals, let's say with an autoimmune disease, on identical diets, and one diet only contains 1.5% of the proteins as ATIs. And this is a clear proof. You can also use a 25% wheat diet, but here you have the proof that the ATIs are doing this. So what do? They also can enter the intestinal lumen. In the normal healthy person, this causes modest myeloid cell activation, which itself is not that dramatic. Like any food ingestion causes a mild inflammatory reaction. Here it's more specific, a mild TLR4 activation. So some release of cytokines, but it fades away in a normal healthy individual. However, these cells can, once they are activated, the myeloid cells, macrophages, migrating monocytes macrophages, they can leave the gut via the circulation. And they do that, especially in patients with autoimmune diseases, where you already have ongoing T-cell mediated autoimmunity. And these T cells, then when the activated myeloid cells by ATIs in the gut reach the extraintestinal organ, they can promote ongoing autoimmunity by promoting antigen presentation and autoimmune reactions via the myeloid cells that are activated by the ATIs. And we have shown that in many models of disease, be it inflammatory bowel disease, be it in NASH and fibrosis, in lupus, this is unpublished, in multiple sclerosis, and adipose tissue inflammation and insulin resistance. So there are certain other mechanisms. They can also interact with the microbiome, and they can promote autoimmunity, and not only autoimmunity, but also classical allergic reactions. So I will skip that quickly. So this is an example of experimental multiple sclerosis. This is the EAE model, and you just vaccinate the animals against a CNS protein, a myelin oligodendrocyte protein, or basic protein. And then you can induce in these normal mice an MS-like symptomatology with limb tail paralysis up to hind leg up to 4 extremity paralysis. So this is scored, and this occurs then within 2 weeks and peaks after 2 to 3 weeks and slowly comes down again. This is the red line. This is a diet that contains a minimal amount, a basic diet of ATI proteins in red. When you remove the ATIs, you have the clinical symptomatology in black. So the clinical symptom score is highly significant reduced when you omit these ATI proteins. And when you look at the T-cell reaction in the lamina propria, this is the dendritic cells, activated dendritic cells. The ATI-fed MS animals have 2.5-fold more activated dendritic cells. If you look into the mesenteric lymph nodes, and that shows the migration of these cells, and you isolate cells and re-stimulate them, then you have about 50-fold more activation in the ATI-fed animals. And when you look into the central nervous system, there you can find the so-called encephalotogenic T cells with a certain gamma interferon producing profile, and these are also highly significantly increased. And this has been published last year, and we have also in parallel performed a proof of concept study in MS patients, 2 groups, fed for 3 months a wheat-containing versus a wheat-free diet. And there we see improvement in pain scores. They are all moderate activity, of course, under drug treatment, not maybe the ones that have the best effect on such an intervention. These patients improved in their pain scores and in their peripheral surrogate immune profile in terms of reduction of pro-inflammatory immune cells in the periphery. It's a 100 immune cell FACS analysis, which is a surrogate of CNS events. So ATI act as an immune adjuvant. The effect is dose dependent, so it's not like celiac disease, so you can tell the patient with autoimmunity, you can just tell the patient, reduce your wheat consumption by about 90%. That will do the most of the job. So in this regard, we have done quite a few studies that are published. Familial Mediterranean fever, dramatic difference, multiple sclerosis, and a study, which I will show you in the last slide, on PSC and ulcerative colitis. And we have done a study in lupus, not published yet, and we are just now doing a study in rheumatoid arthritis, plus minus wheat. So when we come to MASH and MASLD, because we are liver people too, so in a mouse model, we can show that all parameters, insulin resistance, fibrotic signals, inflammation are improved in an ATI versus ATI containing diet in an amount that is equivalent to human daily consumption. That is important to note. And we have just published almost a year ago a study in patients with MASH, and they have several parameters that are modestly but significantly improved on a wheat-free diet, although they do not really lose weight or have any indirect effects of a wheat-free diet. This is the study in patients, a small proof of concept study, 16 patients that were put in a crossover design on a wheat-free diet controlled for compliance with urinary gluten peptides for 3 months. And here you can see that the patients that were in the phase of the gluten-free diet, these are the orange patients, and here the patients at the same time had ulcerative colitis, which you know is frequently connected with PSC. And here we look at the gut, at the sigma, or at the rectum. Left side, the couple is rectum, right side, sigma, pre and post. And you can see that post the gluten-free diet or the ATI-free diet, certain inflammatory parameters as determined by PCR from biopsies improve significantly. These are just some examples. And what is very interesting to us, that the best surrogate marker of liver fibrosis progression, that is thrombospondin 2, a marker of the PSC fibrogenic activity, because we didn't liver biopsy the patients, dropped essentially in all the patients and all over very significantly. And this is a very good parameter for fibrogenic activity in PSC, in MASH, a general fibrosis parameter. Also TSP4, a related protein, dropped. So, okay, a larger study is now planned in the European PSC Consortium, which comprises 100 centers due to these interesting effects on PSC activity. So ATI sensitivity, okay, I would skip that. Practice recommendations can be assumed to promote all chronic inflammatory diseases, especially autoimmune diseases, and the recommendation is a largely ATI-free diet, and then you just ask the patient even after 4 weeks, how are you doing? And there are several IITs still continuing. So this is again the summary. If you are interested, we have published that even in English, wheat syndromes. You can get it via the internet. And so essentially, although it's a few years old, it comprises all these things and also the signaling from the gut to the periphery in general. Okay, so we can't and perhaps don't want to live in a gluten-free world. That will also change the art scene maybe if we would do that. Many investigators involved in these gluten, ATI, etc. related studies. quite a support also in many years. Also in our own company, we developed some treatments also for liver disease, and thanks to the study collaborators. So I think I will stop here. I'm a little bit over time, I guess, but maybe we have a few minutes for some questions, discussion.